If you've got long COVID or ME/CFS, you'll know very well that it's not all in your head. But unfortunately, not all of the medical profession have yet to come to the same conclusion. And this isn't a new problem. The ME/CFS community have been battling stigma for decades. It's also a complex issue connected to the way medics are trained and embedded in medical hierarchy. It's also connected to sexism, racism, and many other forms of judgment. So, what are we to do about it? In this film, Dr Asad Khan and I talk to a panel of experts to get their views, but first, we'll hear testimony from junior Dr Kelly Fearnley, who faced an experience that many of you might find familiar.
Thank you for inviting me to talk today. I'm 35 years old. I'm a foundation doctor. I caught COVID in November 2020 after being deployed to work on a COVID ward. I've now been ill with long COVID for 8 months. So like most people, I had a mild, moderate illness initially. On day 9, the illness kind of took a little bit of a turn for the worst. I woke up with right eyelid edema and a mainly right-sided urticarial rash. In week 3, I mistakenly thought I had recovered. And then week 4, I went back to work and I didn't last very long on ward round. I became short of breath, and that hadn't been a feature before. But I became short of breath at rest, felt very dizzy. I made it home, and then that was the start of my long COVID journey. I actually became very unwell very quickly. I had a resting heart rate of 140 beats per minute. This would elevate to 160 if I climbed the stairs. I physically wasn't able to get out of bed. I wasn't sure what was going on. And I started having violent entire body shaking. My body would shake. At one point, I had altered consciousness, and I called 999. I was taken to hospital again, and this time, because I'd been a few times, I saw a senior registrar. I had a chest x-ray which came back clear, and I had bloods which showed maybe a mild infection. So when the investigations came back, the doctor came back to the bedside. He said I could have long COVID, anxiety, or reflux. It was quite clear though that he thought I was suffering from anxiety. He'd seen sinus tachycardia on an ECG. I'd told him about pins and needles in my limbs, which, as you know, you can get slight tingling in your fingers and toes when you breathe fast and blow off your carbon dioxide. That wasn't what was happening. I had pins and needles almost going into cramp. I told him that I wasn't well. I really felt unwell. I was having attacks of breathlessness. My lungs and airways felt very narrowed. I overheard him speaking to my brother, and he was describing me as anxious. And at that point, I knew I was going to be discharged, and I felt very, very poorly. Very, very poorly. So poorly that I did worry for my life. But he'd obviously joined the dots in the wrong order. He'd heard me say cyclic attacks. He'd heard pins and needles. He'd seen sinus tachycardia on an ECG. He'd heard one episode of anxiety and depression. And for him, I was an anxious little girl. I wasn't taken seriously. My concerns weren't taken seriously, despite me being a doctor myself. I feel down by my colleagues. At a time when I needed help, that help wasn't there. Sadly, I know my experience isn't uncommon. I know a lot of long haulers have been dismissed with anxiety or had their symptoms dismissed with anxiety. And that's simply not the case.
The panel had a chance to watch Asad's interview with Kelly before the session, and we'll get their thoughts on it after their introductions.
My name is Brian Hughes. I'm a professor of psychology at the National University of Ireland in Galway. I'm a research methodologist and a psychophysiologist, and I have written a lot about the state of psychology, the replication crisis, the PACE trial, chronic fatigue syndrome, and related issues.
Thank you. Sean.
So my name's Sean Cresci. I'm a doctor. I work as a specialist registrar in palliative medicine in Scotland. And I, unfortunately, I'm also a patient. So I have long COVID, which means that I'm not able to work at the moment due to my symptoms.
I'm a medical practitioner. I'm a specialist in pathology. My specialism is in cancer genetics. I caught COVID end of February, beginning of March 2020. 6 weeks after the worst of it, I then went down with what we now realise is long COVID.
Hi, I'm Sarah Graham. I'm a freelance health journalist, specialising in women's health in particular, but I'm also currently writing a book exploring the gender health gap across all areas of health. So I'm particularly interested in women's experiences of their illnesses being psychologised and feeling that they are dismissed or not taken seriously by healthcare professionals.
So my name is Dr Nina Muirhead. I'm an NHS dermatologist. I haven't had long COVID. I actually had glandular fever in 2016. Told colleagues, well, I'm not going to become deconditioned and take to my bed. I've never been anxious or depressed, but I have been severely unwell with multi-system symptoms, neurological condition. I have a diagnosis of ME/CFS, and was shocked really actually as to how little this is understood by the medical profession. And I could see long COVID coming. I could see that there was going to be a big fallout of post-viral multi-system symptoms, and unfortunately misdiagnosed as anxiety in a lot of patients.
I just wanted to make it very clear that what we're here for today, this is for our viewers, is not to sort of diminish the importance of psychology or psychiatric illness, or to say it's any less valid than physical illness. This is about the fact that if you have a biomedical illness, then the primary treatment and the primary investigation should be biomedical. Sadly, that hasn't always been the case with chronic illnesses. And whereas psychology, psychiatry in these cases can be very useful, including in long COVID, it's more as a means of helping deal with the consequences of the illness on one's mental health, rather than a primary treatment itself. So I just want to make that very, very clear in case we're accused of, any kind of hierarchy of physical versus psychiatric illness. I just wanted to throw it open to the panel really about the video that you have just viewed, in which Dr. Kelly Fearnley gave, well, I would say harrowing testimony of her experience. And this would welcome sort of any reactions, thoughts on that to start off with.
I thought that Kelly's story was, incredibly upsetting, very difficult to watch, but also quite depressingly familiar. I hear a lot of very similar stories, particularly when she talked about that experience of feeling that she was patronized, that she was treated like a silly little girl, that it was dismissed as anxiety because she had a previous experience of having panic attacks. So I, since 2018, have been running a blog called Hysterical Women, which was really the inspiration behind the book that I'm writing at the moment. And that blog is just full of those stories, basically, of women, you know, whether it's with chronic illnesses, whether it's, you know, going to A&E in acute pain, being told, oh, there's nothing, your x-ray doesn't show any problems, your scan doesn't show any problems, we've done this blood test, it's clear. And really, I suppose doctors kind of over relying on that kind of objective testing at the expense of listening to their patient. And so, yeah, for me, it was, you know, for all it was very upsetting to watch, it was also very unsurprising, actually. A lot of the things that Kelly talked about, you know, were things that I hear an awful lot.
Kelly has wondered to me whether there's other elements of bias here as well. So if she wasn't 5'1", if she was male, if she was perhaps more senior, perhaps if she wasn't from a working class background with a northern accent, would that have made a difference to how she was treated? And I think she's right.
Actually, Sarah, that's what I was just about to ask, actually, was whether or not ethnicity was another theme that came out in your work, because I think there is also evidence that, like, say, a Black woman is less likely to receive pain relief compared to a white man. And I think Kelly's story, that was certainly one of the main things that stood out for me as well, was that she was made to feel like that silly little girl. And I have kind of felt through my experience of now being a patient with an emerging disease that not much is known about medically, and the responses that I have had at times, which people respond to my history of my physical symptoms with as if I had just told them that I was having psychological symptoms. That actually, even though I am a man, what I'm possibly experiencing is the result of ingrained misogyny within medicine, because obviously not directly towards me as a man, but because perhaps the majority of patients who do have chronic immune-mediated conditions, autoimmune conditions, are female. I think that there's a propensity towards female sex in long COVID as well. So I do wonder, you know, even though people like me, Asad, there are still men who are experiencing long COVID, whether or not we are actually all experiencing the repercussions of medical misogyny.
I had a question for Brian. I was wondering if you could give us a sort of a potted history of how the science has developed in the last 20 years, or 30 or 50 years, and how well accepted that's been on the front lines.
Yes, I think the historical background is very important, because we often focus on the here and now, and we see things as new controversies, and we look for new causes. But I think, as Sarah has alluded to, these trends have deep historical roots, and I mean, a potted history is possible, but it's actually a comprehensive picture, and it goes right back. I mean, there's always been a cycle in psychiatry of swinging from physical theories to psychological theories and back again, and even traceable to the establishment of the asylums in the 19th century, the emergence of an anti-psychiatry movement, all the way up. But without getting into too much of that, psychiatry has often been seen as a dumping ground for difficult patients. In the mid-19th century and all of that history up to the mid-20th century, we had poor houses and industrial schools and mother and baby homes. And about half the beds in the NHS in the 1950s were occupied by people with mental illnesses or impairments. None of these people weren't mentally ill a lot of the time. They were disadvantaged and excluded and marginalized people who were dumped into a sort of a psychiatric or psychological category. And I think that history is definitely lingering in social attitudes and in clinical attitudes to this day. There's also a kind of a political dimension, some would say, and it takes us right up to the present, really. Certain physical illnesses cost money, and it's easier to pretend they don't exist. And when you look at, say benefits, social benefits, or illness benefits, it's if something is categorized as a malingering or a fake illness, then it costs less. Less money is set aside for it. And even when we talk about reopening the economy or reopening society after COVID, the people who are in favor of ignoring COVID are also in favor of ignoring long COVID. They don't want to pretend it exists, because then they'd have to deal with it. They'd have to shut down the economy. They'd have to, take the hit financially. So there's all sorts of sociological, sociocultural influences discouraging people from taking these seriously. And that does overlap with the story of ME/CFS, as I'm sure you're aware of. In the UK, about 250,000 people probably have ME or CFS or a related condition. And yet the standard of care is to direct these people into a psychological service. And there's a dark history to that in terms of, key researchers in the 1980s and 90s and early 2000s being funded by insurance companies and even the Department of Work and Pensions to investigate these. And these are entities with vested interests in categorizing these illnesses as non-existent for all intents and purposes. So there are many influences that come into play. And I think with long COVID, we're seeing them unfold before our eyes.
Nina, question for you. So you've had a bit of a journey with physical illness, but also perhaps your thoughts and beliefs about ME/CFS itself. That's evolved over time. Perhaps you could shed some light on that.
Yes, so initially I had the sort of general lay impression of post-viral illness and post-viral fatigue to be to do with deconditioning, possibly a bit of burnout, probably a little bit of depression. And then I got ill, and I actually thought I had a brain tumor or multiple sclerosis because I had large numbers of multi-system symptoms, from changes in my bowel habit to difficulty breathing, chest pain, shortness of breath, nocturia, high temperatures, sore throats, lymphadenopathy. So lots of very physical symptoms, and ones which I was actually initially ignoring. So a little bit like Sean, I was carrying on working, took a couple of weeks off, tried to go back to work, managed about 4 days, took another week off, managed half a day, and then in the end I was signed off sick, and it took me a year to 18 months to be well enough to go back. And when I returned, I was mainly housebound and using a wheelchair to get out. I had a disabled badge, and it took a lot of input from my workplace to make modifications to adjust to my physical illness that I had. And obviously it takes its mental toll. But the stigma that's associated with post-viral disease and the attitudes towards it being mainly driven by mental sort of thoughts and feelings and behaviours of the patient have made the patient react to make it even more black and white in terms of saying, no, this is physical rather than mental. But actually, just like any other patient with MS or cancer, they need psychological support to adjust to that illness. It's hugely shocking to find yourself in a wheelchair in your 30s and unable to care for yourself or your young family. So that was my experience, and it was so raw and real and severe that it made me open my eyes to this huge number of patients. I mean, 250,000 patients in the UK who were going through exactly the same thing, and the medical profession really have a blind spot on this point.
Can I ask what sort of reactions you got from primary care or the places you went to get help when you first sort of became ill, and what your experience was there in terms of enlightenment or not amongst the sort of the healthcare providers?
So really mixed. My current GP has been outstanding. She's been really excellent. She recommended mobility aids like a wheelchair, nutritional support, B12 injections, referral to neurology. So she's been outstanding. However, I have had extremely senior consultants be extremely dismissive. So I've had comments like, I don't think you're malingering, and other comments such as, what you need is a social life and to go out with your husband more. Or just, are you feeling better now? Just a complete lack of comprehension as to how horrifically debilitated I have been, to the point where I couldn't read, I couldn't watch TV, I could barely eat and digest my food, I couldn't have a conversation for more than 10 minutes. So to be sort of chivied along in an outpatient consultation, oh, sorry, hang on a minute, completely dismissed as being almost trivially unwell. Oh, you had a virus, you know, you're getting your strength back now, sort of thing. It just shows the profession have underestimated. They've hugely underestimated the impact of post-viral disease.
Sarah, what is it about diseases that primarily affect women that lends them to being psychologized? And as Sean made a very important point there, those diseases, if they strike men get kind of lumped in the same narrative, because we know that in women autoimmunity is more common. So surely the thinking should be, okay, well, this disease seems to affect women in, preferentially, so let's look for an autoimmune cause here. Instead, we go down this rabbit hole of it's in your head. What attitudes, what history has led to this?
I mean, I think the short answer is sexism. It's medical misogyny. It is that kind of very deeply ingrained, patriarchal attitude that women can't be trusted, that women exaggerate, and I wanted to come back to Sean's point actually, because I think it is a really interesting one. And as I said, it's very much an intersectional issue where it's not just about gender, but race and class and all these other aspects sort of play into it. But I think one of the areas that I'm really interested in is about research and funding and which conditions are prioritized. So there was some interesting research published last year where it was based in the US, so it was looking at NIH research funding. And basically they had looked at the amount of funding that is given to various different conditions relative to the burden of those diseases. And they had looked at kind of which were most overfunded and which were most underfunded. And they then had looked at the gender split of those diseases. So which diseases were fairly gender neutral, which ones predominantly affect men and which ones predominantly affect women. And every single one of the most overfunded conditions were ones that mostly affected men. And every single one of the most underfunded were ones that mostly affect women. And that included things like ME/CFS, it had included endometriosis, migraines, anorexia, all the ones that you would expect, really. So I think, it's sort of a combination of this attitude that women exaggerate and are hysterical and go to the doctor about any old thing, combined with the fact that we know much less about conditions that mostly affect women because they're not prioritized. And I think, I one of the things I often wonder is, if 75% of ME/CFS sufferers were men, would there be the research? Would we know more? Would we have more effective treatments? And I suspect that the answer is yes. So I think, those are kind of the two really big things for me, is that actually doctors don't know enough. And in the absence of that knowledge, it's easier to say it's all in your head than to say, I don't know. Medical science hasn't given us the answers.
Yes, I think that's true also at a global level. If you look at the focus of research funding on illnesses that affect people in developed nations, as compared to illnesses of the developing world. And it affects, it's also been observed with across ethnic groups within developed nations. So illnesses that affect white people essentially in rich countries, white men in rich countries, they get a disproportionate share of research funding. And it creates this kind of echo chamber effect where people see medicine in terms of the white developed man, and draw comparisons. If a woman is unhealthy, it's in comparison to the man, and all the theory is developed from there. So the idea of illnesses that affect women primarily are seen as outliers rather than illnesses that affect half the global population. And I think it bleeds into the way in which doctors do their jobs on a day-to-day basis. A lot has been said about the idea that it's concluded to be psychological if there is no physical effect, when really it means if no physical source can be found. But that depends on what tests you do, and often the cause is not. It's not so much it's not there. It's not looked for. And doctors recommend different medical tests to different patients. And there are very clear patterns on gender lines in this respect. It's been long established, but continues to be researched. When patients present to a GP, for example, with chest pain, for men and for women, it's equally likely to be related to cardiovascular disease. It's more likely to happen with men, but if chest pain occurs, it's equally likely in both genders to be rooted in cardiovascular disease. But men are twice as likely to be sent to a cardiologist, because doctors see cardiovascular disease as a male illness and see women pain as a psychological sort of experience. So the end result of this is profound, in that women with cardiovascular disease markers are less likely, or half as likely, to be sent to a cardiologist, and therefore are more likely to develop further illness and complications. It's profound. Just another study to mention in this respect, and I'm sure Sarah has a lot more information than I do on this, but a couple of years ago, a study in the United States looked at cases of cardiac arrest that occurred outside hospital settings. So about 300,000 people a year have heart attacks outside hospitals in the United States. And this study looked at 20,000 cases drawn randomly. And it found that when a man or a woman has a heart attack in a public place, half the men get CPR from bystanders. So members of the public, colleagues, friends, family members. Half the men do, whereas only a third of the women do. So even when people are experiencing cardiac arrest in a public place, there is a cultural gender assumption to the way in which, to the causal theory, if you like, the shared causal theory for that illness. So it's not only medical professionals, it has actually bled out into the wider culture, this idea that when men are sick, it's serious. And when women are sick, there's probably some explanation for that doesn't involve physical illness.
Yeah, well, as a bit of a specialist in the theory and practice and strategy of lab testing, and that extends to any investigation in the end, even asking a question in a history or doing an exam. It all comes down to the generally bad way in which we teach medical students, I think, and therefore young doctors, about what testing actually is. And it has to do with the prior probability of disease, and then a conditional probability depending on the result. And then you get a posterior probability, which then enables you to go down your differential diagnosis. And this idea that having a normal result equals health needs to be completely bashed out completely. So it isn't. It's simply with reference to a reference range for any given population and a test that's been done on them. And for any given patient, their own normal range may be much, much tighter than that. Yeah, so it does come down to how people go through and sort out how they investigate disease. And if we could try and teach that better, people perhaps would be, well, doctors would be protected from damaging people because they don't understand why they test things and what it tells them.
Yeah, I couldn't agree more. It seems like the jump from the tests are normal to this is psychological is instant. You know, the fact that a test is normal means that, well, you look harder. The test hasn't been developed yet. You treat symptomatically in the meantime.
Yeah.
At the very least, you show empathy. And that's just missing. Sorry, Ian, I interrupted you there.
That's all right. It's the delay bit that always messes up. I mean, Brian's point about the rate at which people's chests are jumped upon, depending on your gender, right? That comes down to perceived prior probability of physical illness versus some other cause. Let's call it psychological. And clearly, people perceive the prior probability of psychological illness in females to be very high, when in fact it's probably as low as anything. And it should be virtually zero, actually, in your testing strategy. Whereas in males, clearly the prior probability is perceived as being relatively high. So, ergo, you act and do something. That's what's going on in their minds, I think. They're biased because of age, because of what you look like, because your skin color, because your gender. You know, whether you're a professional or a lower socioeconomic class, to put it like that, if we're allowed to sort of talk about that. But all those factors are what human beings use to judge all the other human beings. And we have to kind of do something about that, I think.
Yeah, I was just going to add, I feel like something's gone wrong in the system somewhere. I don't know if it's at the stage of training or what, because I agree with what you said about testing, but also to go back to what Asad was saying about the very least that you can do. So when I was a medical student, it was drilled into us that the majority of the clinical information that you get that's necessary to treat the patient comes from the history. Yeah. And I feel like for, you know, long COVID, ME, CFS, other conditions which have been put down to hysteria or similar terms, there's this kind of complete decision to just neglect the clinical history as if it's irrelevant and just say, oh, well, your tests are normal to you, so therefore there's nothing actually wrong with you. And the other thing that comes to mind as well about clinical training, which I suppose is a bit of a contradiction from that, is I suppose what I do remember from medical school was that we were certainly made to feel like it was a very bad thing to ever not know the answer. And I remember very clearly being in a kind of a simulated workshop with a simulated patient, and an older consultant who was either retired or very close to retirement giving me a scenario and saying, and what are you going to say to the patient in this situation? And I didn't know what the diagnosis was. So I said that I would tell the patient I didn't know. And that was the wrong answer as far as his consultant was concerned. And he basically berated me and said, you never, ever tell the patient that you don't know. And if you ever tell a patient that you don't know the answer, then they'll just lose all faith in you and in the medical profession. And I think obviously that's rubbish. And we all train for a long time, and we all train in our individual fields for the reason that medicine is so vast and it's not possible to know everything. And patients can present with any constellation of symptoms, and it's quite ridiculous to consider that you're going to know the answer to everything. And that's why we all need to talk to each other as well, and ultimately believe the patient.
Yeah, it kind of comes down to a kind of humility, really. that's
Yeah.
missing from not just doctors, but also from psychologists, because in my experience, many psychologists are all too happy to receive the business, whether that be research opportunities that kind of prioritize the psychological dimension, or whether it be the provision of a psychological treatment. So, I mean, psychologists are not, doctors, medical doctors are not alone here in contributing to this cultural problem. And it does come, as you mentioned earlier, Ian, it relates to training, because there's a complete absence of coherent scientific reasoning here. I mean, the scientific method was invented to overcome the problems of arrogance and arguments from authority and things like that, and the expert knows everything. And the role of uncertainty in science is critical. And the idea that you don't know, the only reason scientific research takes place is because we know that we don't know things.
Yes.
Yeah. So the whole credibility of knowledge is dependent on accepting that there are things we don't know, and therefore we need evidence and so on, and we gather evidence and whatever. You remember one time there was a belief that people who had ulcers, perhaps it was because of stress. So rather than saying we don't know the cause of ulcers, we just invent a cause, like the God of the gaps fallacy from medieval times. What happened there, we don't know. Well, God made it happen. So it's like a psychology made it happen, is the explanation people have. And it's really, it's interpreting the absence of evidence. And there's a kind of a cliche in this area of philosophy, that the absence of evidence is not evidence of absence. So just because you don't know something doesn't mean that you do know something positive about the absence of that knowledge. And that's a bit convoluted, but where I would bring it back to ME/CFS and long COVID is that there has been in the last few years a tendency to use the label MUS, medically unexplained symptoms, to describe a category of patients who have illnesses that cannot be accounted for by the available physiological tests. But rather than say these are illnesses for which there is no clear test-based explanation, they are simply given a label, medically unexplained symptoms. And it sounds like there's an acknowledgement there that we don't know something, but actually it isn't, because the whole MUS literature is based around psychological causes. The MUS is really a euphemism for hysterical illness. And it does come down to a lack of skeptical reasoning in the people who are using this knowledge and generating this knowledge. And I wouldn't be the first to point out that there's a lack of scientific competence in medicine as a profession a lot of the time. It's wrong to generalize, of course, because there are many brilliant scientists, but you're quite likely to encounter a clinical practitioner in medicine and psychology who is actually useless at science. I'm afraid to say that's just a very common reality.
So I've done quite a lot of qualitative research on the interaction between patients and their GPs with patients with ME/CFS, and they know full well that their GP doesn't know the answer. All they want to do is just be believed and listened to and supported, and maybe have an open mind to symptomatic treatment with medication. And in fact, what was really interesting, and that came out of looking at the transcripts, was that a lot of patients said that if they were on the other side of the table, sat in the doctor's seat, that they may not have necessarily believed them to begin with either. So they had this huge understanding as to how the healthcare professional might feel, and wanted to work with them to come to some sort of agreement as to how to proceed. But the total dismissal or the shutting down of their illness as a physiological entity was a huge barrier to progressing past that point. So the patient had empathy with the GP and was not receiving it in reverse. And they knew full well that their doctor didn't know what to do. And that, I think think was one of the biggest things that came out of that research.
That's very interesting. I mean, I've spent most of the last year, as I'm sure others have. I don't expect my doctor to have any answers. I don't expect them to have any magic treatment. I do expect to be heard fairly, and I would like to have serious, actionable, treatable pathology found and acted upon. I had a whole load of MRI scans on the 1st of February from neck to navel, and if they'd gone 8 inches higher, they'd have found then that I probably had a brain full of clots. And my neurologist recently observed, in normal circumstances, we'd put you on warfarin for 6 months, but we do not know the underlying reason for your thrombosis. So we will not stop you after 6 months. We need to find out what the potential cause of that was, because this is a new disease and we do not. I thought, I'm in totally safe hands here. This guy knows his uncertainties. And that's the kind of person I want treating me. Thank you.
I wanted to add to Nina's point, really. You know, a lot of the patients that I work with and that I speak to talk about, you know, the exact same thing, that what they want is to be listened to, they want to be heard, they want to be believed. And actually for them, that kind of the lack of validation, the being told it's all in your head, when actually they would be much happier to hear, I don't know, let's work together, let's figure this out, you know, let's put a plan in place to try and understand what's happening. You know, the lack of that validation actually is what causes the kind of PTSD that Kelly spoke about, you know, of feeling that the person who should be on your side, who should be taking care of you, is not, that you know, that they're against you. And it's interesting, I had a female medic get in touch with me at some point last year, and she said that she related to a lot of the stories that I share on the blog, and that she, you know, even as a doctor herself, had experienced similar kinds of things to what, you know, the women on the blog were talking about, and you know, from her colleagues, from people who she expected, because she was a doctor herself and she expected that they would take her a bit more seriously, but they didn't. And her view, you know, very much was what Sean was saying, that they could not allow themselves to say, I don't know. They couldn't bring themselves to admit that kind of lack of knowledge. And that, I think, is a really big problem. One of the things, I suppose, that I find quite interesting about long COVID, and, you know, I know there's been, you know, perhaps a little bit of resentment in areas of the ME/CFS community that long COVID is kind of getting all of this attention and they've been ignored for years. But actually what I think is quite interesting about long COVID is, you know, the fact that so many people have got it all at once, and that, you know, because of the nature of COVID-19, a lot of those people are doctors. Suddenly, you know, you have doctors like Sean and Nina have both said, who have this new insight, you know, and I just wonder whether there will be a kind of bigger knock-on effect of that, whether, you know, doctors like yourselves are now in a position to educate your colleagues.
It really is a complex business, isn't it? So much so that I've had to split this discussion into 2 parts. So next time we'll be discussing why it's so hard to stick up for yourself as a patient faced with this kind of treatment, and just what you might be able to do about it. Till next time.